The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Welcome to our Safe and Calm webinar for this morning on Friday. We just have a few general updates this morning, and Dalton will focus a bit on some recent movements in the legislature. But our main discussion will be about testing for all residential settings. A lot has happened in that area since last we talked on Wednesday. And at the very end, we will have a very brief CON update for the nursing homes following the Standards Advisory Committee meeting that occurred yesterday. So we'll end with the nursing home CON information so that other provider types can jump off the call at that point. We were told by Dr. Gordon at MDHHS on Wednesday that nursing homes could expect directives coming as early as Friday for testing, and that testing will be mandatory in their view. We did review a draft of those requirements, and Dalton will be sharing some of our responses to that as he discusses our ongoing advocacy. What's confused the issue a bit is that on Wednesday, actually prior to our meeting, MDHHS put out guidance on MyHand, which included almost the exact same criteria and verbiage that was discussed as mandatory for nursing homes, but it was guidance for all healthcare settings, residential, congregate settings. And of course, it still doesn't define what they mean by congregate settings, but we do intend to, we believe that they intend to not include independent living there from what we can tell so far. So mandatory testing guidance for nursing homes might come out as a final directive as early as today. And we're going to review the recommendations. We have not seen the absolute final guidance, but we're going to review the recommendations and the things that they put forward this morning. So we think that nursing homes should really start planning on instituting these recommendations soon. It's possible that they'll tweak this guidance a bit before that. And we have offered ideas back to them. But since the guidance as they've written it pretty much does align with the CMS CDC recommendations, we would be surprised, very surprised actually, the department's going to budge very far about this. And do remember that these are the same requirements that let me reframe that. These are the same recommendations. It's a requirement for the nursing home, but they're strongly recommended for other residential settings as well. So with that, we're going to turn the presentation over to Dalton, who's going to give us an advocacy update.
Good morning, everyone. This is the agenda for the overall thing. And as a follow-up to Wednesday's webinar, I initially wanted to talk about a couple of things we discussed there. We have had some action on the electronic monitoring bill. And then I wanted to give an update on 690, which is the budget bill that the Senate is allocating those CARES Act dollars. But to start off, I wanted to touch off on the letter we sent to Director Gordon regarding the executive orders and the clarity around there. I feel that on the last call, I may not have made things as clear for everyone as they should be. So on the bill, we did ask for really four main things, or not in the bill, in the letter. We asked for four main things. The first was clarity around what independent living providers should do, specifically what qualifies as independent living, and we urged for guidance around visitation and community access. And then we also noted that guidance is being drafted for HFAs. Secondarily, we asked for the continued use and the ability for providers to use non-certified staff in their settings to provide care. A third, we asked for clarity around what is communal dining, specifically what does communal dining mean in each specific setting and level of care. And then lastly, we also asked for the allowance of outdoor visitation for all levels of care. And on the next slide, you'll see a letter or the letter that we sent, similar to last week. Moving forward from here, we have Senate Bill 77, which is the electronic monitoring bill that we discussed last Wednesday. And on Wednesday, we said that we expected the bill to come out of Senate committee. It did come out of Senate committee yesterday with a substitution added to it, which did change some of the language to be a bit more provider friendly. But where the bill is now is that it needs to still be passed by the full Senate, and then it needs to go and be reported to the House of Representatives, and then it needs to be sent to a committee in the House of Representatives, and then passed out of that committee, and then passed by the full House, and then the governor needs to sign the bill. And I plan to do a more in-depth reading or analysis of this on next Wednesday's call, because some things could still change between now and Wednesday. Also, just here, I also wanted to touch on Senate Bill 690, which, as you know, is that bill that the Senate and House are using to allocate some of the CARES Act dollars that are currently under this governor's discretion. This is the bill that contains the funding for those direct care worker payments and the PPE grants. That bill is still in the House, and because the House made so many changes to it, it qualifies the bill to have a points of difference with the Senate, which means the bill has to go past the House, go back to the Senate, pass the Senate before it can then be sent to the governor's desk for signature. So we're still a couple steps away on that one. Moving on, this week, LeadingAge National also sent a letter to Nancy Pelosi, Mitch McConnell, Kevin McCarthy, and Charles Schumer, better known as Chuck Schumer. In the bill, they are urging for the national government or the federal government to provide greater relief for long-term care providers. The 5 essential actions that they're looking for from the federal government or in the next COVID relief package are to ensure access to adequate PPE for providers, ensure access to accurate and fast testing kits, ensure that states consider health and safety as they reopen and in their reopening plan, funding and support for the full continuum of care, and they also would like to see pandemic hero pay, paid sick leave, and healthcare coverage for frontline staff. I included a link in the presentation today, so you can read that letter if you want to. It is 4 or 5 pages long, so it would have looked odd for me to post it on 2 or 3 slides. But if you are interested, there is a link there. The next slide says that goes into more specifics about the letter and what they're going to do. So these are some broad strokes and kind of a summary of the bill here for you, so you don't actually have to read the whole thing if you don't want. Their main ask is that aging services providers be treated as a separate and independent entity as healthcare providers. Really give them their own spotlight and focus. The first thing that they ask for is a $100 billion fund in a provider relief fund. The goals of this fund would be to create more structure and oversight for the funds that have been allocated so far, allocate funding for states to establish COVID strike teams, and create a skilled nursing facility payment incentive program for COVID-19 only facilities. The second pool of money they're talking about is $1.2 billion in a fund to support affordable housing for seniors. Out of this fund, they're looking to cover cleaning and disinfecting PPE, meals, services, and staff costs. They're looking to fund service coordinators, cover installation and fees for wireless internet, and then also establish a 1-year extension for HUD's integrated wellness and supportive housing demonstration. The last fund they're looking to get from the federal government is going to be $10 billion for aging services testing programs. This is the fund to get those accurate and quick test kits and test results to providers. Pretty self-explanatory there. Lastly, as Deanna said, we did have some advocacy regarding the upcoming testing requirements. This on the screen is the letter we sent to Dr. Gordon and Director Gordon, I guess. Some of the concerns we highlighted initially, we would like them to consider a plan to include the analysis of smaller local transmission rates. We feel perhaps the use of these HSAs as the, don't know the word I want to use, we'll say as the plan to determine who needs to test weekly, and the frequency of their tests may cause unnecessary testing for providers who may not have COVID positive and never had COVID positive individuals. We also asked for an exemption from testing staff who have previously tested positive and now meet the return to work criteria. We are also concerned that this may cause labor shortages because of the weekly testing. And we also thought there was a lack of clarity about the depth of assistance that the state can provide to providers. And we also had concerns about the amount of testing resources that will be needed over the COVID pandemic time period. The state has vowed to support us, and I know Deanna will go into this in more detail shortly.
All right, so at this point we will get to some questions. So if you do have any type of question, feel free to type that in, and we will wait a little bit to make sure we get everything rolling in. While that is going on, LeadingAge Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo every year. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. Here's just a quick list of some of the exhibitors who will be at our Solutions Expo once we figure out a new date for that. We just would like to thank them very much for sticking with us through all of this. Right now, I do have one question, and it is, does LeadingAge Michigan have a position on Senate Bill 77, electronic monitoring?
Yes, we do. Currently, we're neutral on the bill, but the testimony we have submitted has asked for a work group to be established. Our point here is that we want a work group to establish. We think that if this can be handled in a way that is beneficial for both residents and providers, we may be able to do some good here for everyone involved. We are concerned that the bill is perhaps a little bit too invasive, but at the same time, we know this is a trend going across the United States. And so we'd like to see something done that can benefit everyone involved and have it be the message that we want to send.
All right, thank you for that. I do not see any other questions coming through, so we will move on. But before we do that, as always, I did want to mention that we do have the handouts attached. I know that some people do have some trouble getting those from time to time. We do have it in a PDF version and a PowerPoint, so hopefully one of them works for you. If not, as always, either today or at the beginning of next week sometime, we will be sending out a we'll be sending out the PowerPoint along with the recording and the Q&A. I actually did have just one more question come in, Dalton. What are facilities to do when a resident is going out to an appointment? Are they keeping them in isolation for 14 days? So I guess that could be Deanna or Dalton on that.
I think that it sort of depends on, I'm assuming this would be a nursing home or HFA, AFC kind of setting. Generally, the CDC guidance still anticipates that you're going to isolate them or at least seclude them in some way for 14 days, yes. They consider the senior population extremely vulnerable still, and even though transmission rates are pretty low in Michigan, they're not necessarily in other states, and they really think that safeguards are still required. We will talk about a little of that coming up, especially transmission rates and where we're going with that.
All right, sounds good. She did mention that it was a nursing home, just so you know.
Right. Yes. Nursing homes are definitely monitoring and secluding for 14 days.
All right, sounds good. So nothing else has come through during that time, so we will move along.
So this morning, I did include a very brief situation update, and I really didn't want to spend a lot of time on this because I know that I do it every week on Wednesdays. But one of the things that came out this morning in an Associated Press article is that cases are rising again in over half of the states. And pretty much those states are reopening with major increases in North Carolina, Texas, and California. North Carolina is reconsidering its reopening right now. So I think that we're doing really well in Michigan. Our numbers continue to look good, but I think everyone needs to remember that this could turn around again, and that we have to think about that as we move forward. So briefly today, I have included a couple slides on the state of Michigan. This is our 7-day rolling average, updated as of yesterday afternoon. Note that our numbers are still good. These are Michigan daily COVID cases. Again, trends are looking really well, really good. For the 7-day rolling average for new deaths, same thing. They've leveled off a tad, but they are pretty low. And the Michigan numbers continue to look good. They do spike a little bit here and there day to day, but over the course of time, they are still dramatically decreasing. So just a moment to look at some of the issues coming up. And I included the MySafe Start map here because that is the map that your testing protocol is going to be dependent on. That is the map on the right as of yesterday afternoon. Last week, the entire map was yellow with a dark yellow around the Grand Rapids HSA. And that dark gold color is a level 3 medium high risk. So currently, at least that has moved down to medium risk. And the upper lower and the upper peninsula itself have moved down to low risk. So that means as we move testing forward that the people in the upper part of the state are not going to have to test quite as often as others, and we'll talk about that as we move forward. One of the issues that I have is that the map on the right is really the only current data we have about caseload on an ongoing basis. In other words, we don't know what the current numbers are. They keep giving us cumulative, which is interesting, but doesn't tell us what's really going on today. And I've included the cases by county map on the left, what the department puts out. And it's good data, but it has to, some of these cases in Detroit could be really, really old. And Detroit could be doing an excellent have an excellent experience right now with COVID, but you wouldn't know it from this map because it's only cumulative. So we're kind of limited by the data that we have in terms of our thinking. I did include the table from yesterday's website just to show you that they indeed are adding the confirmed with the probable numbers here and including laboratory testing as well. So a report came out yesterday, and it was highlighted by the governor, and I think it's an important report. It's from the New Imperial, it's from the Imperial College, which is a UK university that does a lot of kind of monitoring of COVID across the world. And not Detroit, but Michigan was called out as one of the states with an amazing curtailment of the pandemic pretty early after we started getting cases. So that they anticipate that had we not started the stay-at-home activities when we did, that peak for cases and deaths could have been up to 2 to 3 times higher. So this is kind of a really impressive report. and it really kind of shows that we do at least have our arms around some of it. Moving on a little bit, I wanted to give a brief update of what's going on at LARA, especially for AFCs and HFAs. We're still kind of waiting for some official guidance about outdoor visitation. We heard a couple days, a week ago or so, that there's informal verbal guidance going out to some HFAs and AFCs that they can do outdoor visitation. However, there's nothing official and nothing in writing, so we're not really sure what that's like. The department still has not updated its FAQs since 4:30, and I took a good look at that yesterday afternoon, so we're still waiting for guidance about that. Another piece is that the Bureau of Fire Services will start resuming renewal inspections as of next week on June 15. They will start with those who are most overdue for their annual inspection. They will, of course, schedule with a facility, but no more than 24 hours in advance. And the department wants to let you know that the inspectors will be wearing a mask. They will maintain social distancing. They will be very concerned, though, if you have any COVID positive or suspected residents. And if so, they will not continue an inspection there. So they're going to ask you that up front. And they will also ask you to complete a self-inspection checklist instead of their on-site. They are very much aware that some of your inspections will be out of date because of the pandemic. And so they will not take adverse actions on that, and they may in fact give you a temporary approval based on that. Fingerprinting, the fingerprinting exemptions are still in effect, but remember there are some requirements about fingerprinting. So we will include the explanation of what you need to do on the LARA website, link here in our Q&A, just for your reference, just to remind you all. So on to testing. So on Wednesday afternoon, the department, actually Dr. Caldoun, put out recommendations, my understanding is through my hand, that called for strong recommendations for ongoing COVID testing for all healthcare settings. And they kind of referenced, and these are their words, an ideal scenario where supplies are fully available and intended to promote testing to rapidly identify cases, including asymptomatic cases. And the guidance can be adapted by local health departments to respond to local circumstances and testing availability. So as I said before, that confused us a bit when we finally got this, because we knew that the department had just told us, in fact, that mandatory directives for nursing homes would be coming out very soon. However, they're pretty much the same recommendations. So those recommendations that they are going to make mandatory for nursing home, they are strongly recommending for HFAs and AFCs, and that's why I thought we would talk about at least what they are in terms of draft here this morning. So these are the proposed nursing home testing guidance, which aligns very much with the guidance that came out with my hand. Mandated practices in skilled nursing and recommended for other settings. Baseline testing of all residents and staff, and that's of course not a surprise because we know the state has been working on that for several weeks. Universal testing of new residents during intake, and isolation of new residents until test results return. So again, that's that 14-day hold on new residents. Testing any resident or staff member with symptoms or suspected exposure, that's not a surprise. So this is the next part, are the kind of the hard parts, but they are in alignment with CMS and CDC guidance, and that is weekly testing of all residents and staff in facilities where there are any positive cases until 14 days after the last new positive. And weekly testing of staff in regions of medium or high risk. And if you go think about the Myself Safe Start plan map, you'll note that except for parts of the northern lower and the upper, all of Michigan is at medium risk right now. So some things to note. Residents have the right to refuse. Staff, you might consider them to be mandatory testing of staff because you're going to be put in kind of a position because you're required to do it, but residents and staff technically could both refuse unless you make it mandatory in your policies for staff. If you don't make it mandatory, I'm not sure what you would do with staff because they obviously are not supposed to be in the building working if they haven't tested negative. So facilities, and this is just for the nursing home piece, must complete a plan for how to conduct testing that complies with the guidance. And the tentative date for that was June 26th, I believe. However, without the final guidance, I'm not sure when it'll be out, so that date could change. And the state will support testing as their capacity allows. And that as capacity allows always, worries us a bit. But they do assure us that they do have funds to support testing in terms of supplies and in terms of actual testing if that's the level of assistance needed. The tests that you can use are listed there, but they're not looking for serology or antibody tests. They are looking for a diagnostic test. And that diagnostic test must be conducted by a laboratory certified for high complexity testing using an FDA approved testing method. So the goals, I think some of the goals are obvious. Rapid identification of cases, including those among asymptomatic persons, containing spread, and preventing poor health outcomes. And obviously, even though I think things feel better now overall than they did several months ago, obviously, when we had a large number of deaths, a large number of cases in some facilities. But with the reopening, I think that there is concern that, as with other states, some of that community transmission can come back. So that is why there's such a huge focus on this. One of the things that the draft guidelines stated was that they identify that for each of these decisions that they've applied an epidemiological risk for spreading COVID, both within and outside of the facility. So what that means is they've identified some rationale. Again, baseline, one-time testing for all residents and staff. That's completed. It's unclear what to do about some staff or residents that have not refused. I think members are going to have to address resident rights of refusal. CMS kind of encourages a policy where if someone refuses to be tested, you treat them as if they're negative. You treat them as if they're positive. Doing all new residents at intake, there's a big concern about a new introduction of infections, again, especially since we're reopening slowly across the state. Which also, implies the need to continue to place new residents in private rooms or observation areas so that they can be observed for the first 14 days. Again, testing for residents and staff. If you have a suspected person, you need to place them in observation or in a private room. Weekly testing for residents or staff if any positive cases. We've considered that to be an extremely burdensome piece. especially for staff and for a lot of the residents with dementia in terms of staff time, PPE. But if you have any positive cases, the CDC is definitely going to expect that you continue to do weekly testing. And then the real concern lies with just blanket weekly testing for staff in medium or high risk areas. And we considered that to be a burdensome area as well, and that's what our letter implied that we sent back to Dr. Gordon. Okay, Blake, you can move. Thanks. So we've developed a couple polling questions here today. We would like to ask so that we have a sense of what the testing needs are, who currently has COVID in their facilities. This is a multiple, this is a question where you can have multiple responses if you have both nursing homes and assisted living level care in your community. Blake, can you put the poll question out there?
Before we do the polls, would you like to go over some questions? I have a list of them right now.
Sure.
Okay. All right. So the first question, are the increases in the states due to increased testing or actual increases?
The experts think it's both. They think that there are, with better testing, that they have higher numbers, but they also think that there is some increases because of the more community closeness.
Oh, okay. One recommendation from MDHHS for testing says, testing at intake to any group living or congregate care setting, even without symptoms. Do you interpret this to mean sniff also? CDC currently says to place new admits in precautions 14-day and then see if asymptomatic or may test for additional confirmation.
Yes, we do understand that CMS doesn't require that, CDC doesn't require it, but it does look like the state is going to require that for SNFs as well. That's at least what was in their draft update, and I believe they're probably going to leave that in. We don't have any indication they're going to take it out, let's put it that way.
Oh, okay. Next one. Is there going to be guidance for HFA exempt assisted living communities with respect to testing?
You know, they fall into a gray area. Independent living guidance has been very gray. We continue to ask for better definitions for these settings. I would say that if you provide services that are more like assisted living, that you should follow the assisted living guidance, and that would be included in testing here. If you are more independent living with apartments and no real services, then I would think differently.
Okay. So at intake would mean we test them upon arrival to us. What if they were tested at the hospital prior to discharge to us?
That question has come up with the state. They don't anticipate that you repeat a test if they were tested at the end of their hospitalization. So you need to look at each case individually.
Okay. Regarding testing at intake, if the okay, no, that's the same question. Okay. Can you define staff? Is it only direct care staff or all staff?
That's a very good question, and I don't think that that has been discussed, and I think that'd be a good question for the department. You might consider anyone who's in your building because you have staff, support staff talking to direct care staff, but that's a question I think that we would formulate and send to the department for their take on that, and perhaps inclusion in their final guidance if they haven't done it already. It could come out as early as today.
Okay. Regarding baseline testing for staff, it took us 3 full days to test 290 employees with a team of about 10 nursing staff conducting the testing. The labor cost is extensive. Okay.
We do understand that, and in fact, we have said that to the department. I think the department's gotten a lot of feedback about that. However, at this point, they are not really budging from weekly testing requirements for staff if indeed you're in a medium or high risk area.
Okay. If you treat a resident as positive, if they refuse, we would not have enough private rooms to isolate each resident who refuses. This is not a manageable approach.
It can be hard. I understand that. I guess it would depend on how many people were refusing. I would work with your local health department and the state if that situation arises. I don't know that there are any good answers to that. I do know that the testing basically is mandatory, so there's going to be some back and forth for certain facilities who perhaps can't meet all of the criteria. And we're going to talk about this a little bit, but the state has agreed, at least as of the last conversation, to put some language in the guidance that says that providers won't be necessarily penalized if indeed they're making an effort toward complying with the guidance.
Okay. This is just a statement. We have been trying to require new residents moving into our HFL independent living community to be tested prior to entry. Local testing locations will not test without symptoms. Very frustrating. Oh.
I would encourage you to send us a specific email. Let us know what area you're in. The state is saying that there's free testing available for staff outside these facilities. So if indeed residents can't even get tested for if they're not symptomatic, I would like to know that and follow up with the department.
Okay. Are tests with 15-minute results approved by the FDA and available in Michigan?
I don't know if they're available. I know that there are some labs that are doing a lot better with turnaround times. And in fact, one of the pieces of feedback that we provided to the state is that a lot of members have told us that it's taken days and days and days, and sometimes weeks, to get a response. At what point does it make to do weekly testing if you don't have the result from the last test? And the department has heard that they're working on more rapid testing. Now, where there is very rapid testing that really works, I can't speak to that specifically.
Okay. Will a test 48 priors to admission or a rapid test suffice for the intake testing?
Oh, I would think so. Yes.
Okay. Are nasal swabs, not the deep NG swabs, approved by FDA and available in Michigan? A less invasive test may result in fewer resident refusals.
You guys are doing a great job of answering questions that I was going to talk about in some later slides. But one of the major responses that we made to the department is the fact that this is such an uncomfortable test, and for persons with dementia or people who have to go through weekly testing, the nasopharyngeal test is uncomfortable at the least. And the CDC, maybe a month or so ago at least, did move away from its preference for nasopharyngeal testing and identified that all different testing, including an oral test, different types of testing would be appropriate. I don't have a list of all those types in my head, but I know that oral testing was one of them. And I think that the state has heard us about that. because even though the CDC said nasopharyngeal is no longer preferred necessarily, that the labs and the kits that the state pretty much has been using is still nasopharyngeal. And so they have identified, since we responded with concerns about that they will try to foster the inclusion of less invasive testing, both for residents and staff. So we look forward to that in the final guidance, and we hope that plays out and when working with these individual laboratories.
All right, thank you. This says, please continue to advocate that testing weekly is tremendously burdensome. We understand the risk of COVID, but for our residents with dementia, this test is very difficult for them.
We understand, and we have communicated that on an ongoing basis, really. Then we will continue to do that. Okay. I think that if community transmission continues to go down, first of all, those areas start to turn blue, you're not going to have that problem if you don't have any COVID in your facility. But also, if community transmission or if things continue to go well, we're hoping that the state will relook at this whole testing guidance in the near future.
Okay. If N95 masks are unavailable and baseline testing needs to be completed, no one has symptoms, how should we safely proceed with testing surgical mask and face shield?
I would communicate with your local health department, and eventually the state let us know. We'll communicate to the state. I do know that regular face masks would not be considered safe to do testing. So that's something that we would have to figure out if it occurs.
Okay. If they require weekly testing, the results are going to need to come back faster. We participated in the National Guard testing, and we're told tests went out of state and could take up to 2 weeks.
Yes, and I think I just spoke to that. The state's fully aware that that's not going to work, and they are working on more rapid turnaround times that make more sense. I don't know if the tests are going to be going out of the state for with all the labs that they plan on using, because the National Guard is only going to be available till August. They're not going to be doing this testing. If the state is going to assist with testing, it's going to be not using the National Guard.
Okay. We tested a large number of our staff too, and it took 10 to 14 days for staff to receive the results, and we did not receive the results for our staff. How can this help?
If you haven't received and you're looking for the results, please shoot me an individual email. That's kind of ridiculous. And again, the state's aware and is working on that problem, because it doesn't make sense if you have to do routine testing to wait such a long time.
Okay. Can you clarify the MDHHS notice for testing that came out says recommendations, but the slide says mandated practices for SNFs?
The guidances that has come out is for all congregate healthcare, actually hospital settings as well. So you have to consider that at this point. But we do know that guidance is coming out that's going to mandate nursing homes apply those regulations and requirements. So it's, according to the department, it's going to be recommended for all other settings, but mandated for nursing homes as soon as that final guidance comes out. Is that it, Blake?
Oh, sorry, no, I accidentally was muted. Is the state looking at each individual county's risk level, or are they only looking at regions?
They're only looking at regions, and that was one of the pieces of feedback that we provided to them. We have kind of strong concerns about the fact that there's only 8 of these large regions across the state. And some of these regions could have 15 counties in them. And the variation among those counties, you might be in a low risk county, but the rest of your region might be medium risk, but you still have to test because of that. And so we were asking for a more local decision about what the best practice would be, maybe coordinated by the local health departments. However, we haven't gotten a response to that. And pretty much the state is thinking always in terms of these large HSA regions. I don't know if they're going to change that or not, but I think it would be a better process if we did.
Okay. Another person says we are experiencing the same for our staff, denied testing at every location in Grand Rapids since no symptoms.
Again, please shoot me or Safe and Calm an individual email, and we will follow up with the state.
Okay. Comment that is high complexity lab tests required under CLIA. Point of care rapid tests are permitted at site with only a CLIA waiver, so unclear how point of care rapid tests would comply. Seems we need additional guidance on permitted testing.
We will work on that. I do think that there are some possible ways that could happen, but again, you're going to have to meet more requirements, and we will work on that piece with the state.
Okay. Can you please restate when the weekly testing is going to be mandatory?
Not technically, I can't, because the final guidance isn't out yet. And the draft guidance that we saw required that nursing homes have a plan to do weekly testing. So to some degree, I think that the actual start date would be based on your individual plan. However, you have to include all of the requirements that the state put in the guidance in your plan. So I would think it would be shortly after June 26th if they hold to that date when they put out the final guidance.
Okay. Someone says, I saw an advertisement yesterday that Rite Aid in Traverse City and Petoskey were offering self-administered nasal swabs by appointment with the pharmacist observing, with turnaround time in 24 hours. That could also work for a nursing home.
Yeah, that would be great. And yes, I do know that the governor's staff or the administration has worked with several of the commercial pharmacies across the state in order to provide testing through their facilities.
All right. Should N95 be used for all cares on COVID suspected or suspected or positive, and or how long after the test is completed and negative?
Okay, so this is kind of a point of contention. We have CDC guidance that states that several different areas that will state that N95 masks should be used for every care if there's COVID in your facility. And then there's another CDC guidance that says you should be using N95 masks for test collection and only for COVID positive people in your community. The state guidance says that you can use a surgical mask for regular care for COVID and non-COVID patients, and an N95 mask for aerosol generating procedures, and collection of test specimens. So for Michigan, I think that some of our facilities are using N95 masks for care of COVID residents, and some are simply using universal masks with a resident wearing cloth masks or covering their face if they can. So there's a little bit of variation here in practice. The CDC guidance, of course, would be at a minimum to use an N95 mask anytime if you have them available for care of the COVID patient. I think that answers your question.
Okay. Any discussion about who pays for this testing, especially for our staff on a weekly basis?
The state has identified that pretty much no one should have to pay for their testing. Medicare and Medicaid will pay for the testing without a copay. Private insurances are required to pay for the testing without a copay. The state's take on that is that that should even be for blanket weekly testing. However, if you have staff with no insurance, or the insurance is not willing to pay for, weekly ongoing testing without symptoms, then there is a state avenue to get free testing, and there'd be free testing sites for staff. And I believe the draft guidance also said that if necessary, the state will come in and help with the testing itself.
All right. Our health department had advised not to continue mass testing because residents are more and more likely to refuse continued testing.
Well, and I would suggest that you let me know which health department that is. Shoot us an email. The more information that we can send to the state about variations in local health department practice, the better.
All right, so that was the last question. So I just have to make one quick announcement before we do get to these polls. We would just like to say, please join LeadingAge Michigan members with our friends and experts from Plant Moran to address use of federal stimulus dollars and other financial and reimbursement issues. While there are many avenues to obtain funding to support our missions, much of the guidance has been confusing and updated during the course of the pandemic. This event is designed to assist members in practical ways to access and use this additional funding in alignment with federal guidelines. Our event is intentionally being planned from noon until 2 p.m. Eastern Standard Time on Thursday, June 18th. That's going to be this upcoming Thursday. So you can go ahead and register. I believe we just actually opened registration right before this, so you can go to leadingagemi.org. And click on our events calendar, and it will be on June 18th. You'll go ahead and you can register there. I believe we will also be sending out something on that later today as well. So please, and so I think that is it for everything that I had to take care of there. Now we can get on to the polls. So I'm going to go ahead and open the first poll for us. So I'm going to launch that. I'll give everybody about a minute or so to answer put in their answers, and then we will move on. I believe we have a total of 4 polls, so we'll probably just take about a minute for each. And thank you for helping us get more information. This is just, we're trying to figure out everything to help everybody.
Okay. Let me clarify one piece. This is, you can have multiple responses here. It isn't just please select one. So if you happen to be a provider who has an HFA or AFC or some unlicensed assisted living and a nursing home, you can answer more than once. Am I correct with that, Blake?
This is actually set up as a multiple choice one answer. Yeah,
okay.
I didn't.
Okay.
I would have to look into.
All right. Well. Okay.
Let me see. I might be able to edit it right now, actually. Yep, I'll still give that another 30 seconds or so. It looks like we've had about 50% of the people vote on this one.
Okay, good.
How do I vote? You should just be able, there should be something up on your screen right now where you can just go ahead and click on one of the 4 answers. And then you should just have to click submit or something along that would be my guess. All right. All right, so we have about 65% of the people who have done this one, so I will go ahead and close this one, and we will look at the results of that.
Okay,
All right, and now we will
great.
move on to our second question here. And now you should be able to choose multiple on this one, I believe. I just edited it.
All right, thank you. So the question is, we currently conduct some routine COVID testing of staff or residents. We want to know whether or not you're doing any routine testing now for your communities. So again, you can click on more than one answer.
It looks like we are having some people having issues with availability to vote. I'm not sure why that is. We're having, like I said, there was about 70% of the people who were able to vote on the last poll. So if you are having issues, I am sorry. I'm not sure why that would be happening. All right, so we'll give this one about 15 more seconds because I've seen the voting jump a little bit. We have about 65% of the people who have voted on this poll. So I'll just give it a couple more seconds and we'll close this and move on to the next one. All right, so let's go ahead and share the answers for that one. All right.
Okay, great, great. So about 33% in nursing homes and 11% in assisted living. So thank you. Okay, that's good data.
All right, so we will, oops, sorry about that. So we will move on to the third one and we will launch this. Someone said, I noticed you need to be following. Yes, you need to be on the live presentation in order to vote. You do not, if you like downloaded the handouts and are going handout like power or slide by slide, you're not going to be able to click on the PowerPoint. You have to actually be on the live webinar and able to be in order to vote. I hope that helps a few people.
Okay, so we are looking to see how many of our members have a COVID dedicated unit, either in their nursing home or in their HFA, AFC, or unlicensed assisted living. So again, there should be multiple responses. Blake, am I correct?
Yes, the rest of them are all multiple responses. I edited all of them or updated all of them. All right, so we'll probably just give this one another 15 seconds or so. It looks like we've been sitting around that 60%, 65% for people who have been voting. So we'll just give this one a couple more seconds and close it down. All right, so we will close that one and go ahead and share the results for that.
Okay, all right, so 59% in nursing homes and about 12% in HFA, AFCs.
All right, and now we will move on to our last poll here. And like I said, we'll give that another minute, minute and a half, and go over those.
Right. So we understand that the CMS guidance has been out for a while, and that weekly testing, we immediately got concerns from members about their ability and the capacity and the resources to do weekly testing. So we want to have a sense of how burdensome you really think this is going to be. If you have concerns about weekly testing, and we will continue our advocacy with the state around that as we move forward. But it's always helpful to have some numbers as we go back to the state. So this is our last question, and this will inform our advocacy.
All right, I did have someone, I will just say this while we're waiting to close that one. Someone said that they can't answer in the poll for some reason, but for this poll specifically, yes, they have very significant concerns.
Okay, good.
All right, so we're sitting about right where we've been for people voting. So we will go ahead and close this one down and share the results for this.
Okay, 75% nursing home and 61% HFA AFCs, and we will use those numbers when we talk to the state. Thank you very much. We know this is a little time consuming to poll, but we really appreciate the input and the data. So moving on from the polling questions, I think that we answered a lot of the questions about testing. So let's move forward and finish that piece. This slide here is about who's responsible for which piece of the testing. And this again was in the draft and proposed guidance. We're not sure what it's going to look like in the final, but pretty much the facility is responsible for residents at intake and residents and staff with symptoms somehow or other to make that happen. But the state can help with weekly testing if there's COVID in your facility, and weekly testing if you're in a medium or high risk area. And we have responded to the state about slow lab response times, and we will continue to do so. Staff refusals, issues with staff without insurance, and pretty much the need for the facilities to track these outcomes over time. So that's kind of where we are with this piece, but this is what the state has offered as who's responsible for what. This came out of the draft guidance that talks about laboratories and getting access to laboratories and going to michigan.gov coronavirus test if you need an up-to-date list of the labs that that have the right testing capabilities. The expectation from the state is that the laboratory should be providing you specimen collection materials, but the state will also help if needed. And Medicare and Medicaid, again, should cover the testing. And we did talk about this a little bit earlier when there were questions. So we can move on, Blake. So that completes our discussion on testing for today. So if you're not a nursing home, there's not a lot more content for you. Before we leave for the day, I did want to give everyone a brief update about the Certificate of Need. So we did review the proposed bed methodology on our webinar on Wednesday. That was passed by the Standards Advisory Committee yesterday, and it will be recommended to the full commission during the June meeting. The 60% occupancy rule will not be recommended to go forward, but the department wants to seriously consider that at a later date, so we can expect that to come perhaps in the next round. They review these provisions of the nursing home requirements every 3 years, so we anticipate that that will definitely show up 3 years from now. One of the things that we were finally informed of was that the March CON Commission meeting was actually completely canceled, which we were aware that it was not done on the scheduled day, but we didn't understand it was completely canceled. And now the vote to include that short-term fixed 85% occupancy rule will not be voted on by the commission until June, which is just a week or so away from now that they have their meeting. So if they approve it in June, the state will need 45 days for public comment. We thought that that would start in March, but it didn't because of the COVID issues. So they will need 45 days for public comment, and 9 of which have to be legislative days during that interim. So from mid to late June, you're going to run through July. And there are no legislative days scheduled for July. So it's anticipated it will take perhaps up to 60 days to get this piece done. And what that means is that some of these applications that were all filed mostly in January and February may actually be able to get through their process because they have to be looked at in July. However, the state has let us know that there are only 3 applications in areas where there wouldn't be competition, or there would be a there are beds available and without competition. 40 applications may go to comparative review. So we think that those 40 that might be going to comparative review, that the new rule might be in place by the time they go to review. But the 3 applications could be going forward. And the state was completely up in the air about whether or not this would happen. And in fact, kind of implied that they didn't know that they had the staff to look at all of these applications in July anyway, because the COVID crisis has affected them as well as everyone else. So it'll be interesting to see how this plays out. However, the original plan, which was to prevent all of these applications pretty much from moving forward unless occupancy was above 85%. Yes, above 85%. But the plan is kind of washed away. So we'll have to see how that plays out. So that's all we have today. I guess, Blake, we should ask if there are any final questions.
So I do have a couple things. And then right before we get to those, again, we would just like to thank our exhibitors and our sponsors both for sticking with us during these difficult times. And we look forward to seeing you and them at our annual conference, hopefully coming up soon. All right. So someone said these look like they both kind of go back to the testing. But they said, note that Washtenaw County Health Department is not supporting testing employees of our AFC, AL, or IL at this time. They did provide the testing for our SNF employees. However, they took the National Guard test back because we never received the appropriate paperwork or labels.
Okay. I will continue to send me those kinds of things, if not through the Q&A. Because we can see who's asking the question on the Q&A, and also to our website, our email addresses, so that we can follow up with the state. When we talk to the state in general terms, the last time we talked about along the local health departments, there's a little bit of reluctance about the messages, let's just say, on the department side. So we would like to have some clear information about what isn't working, and we can move forward from there.
All right. And then we did baseline testing last week because of a positive staff. We didn't do testing this week because it took 3 days to do this. Now, will we need to repeat baseline testing since we didn't follow it up the next week with another round?
Well, yes, but not because you didn't follow it up, but because when the guidance comes out, it's going to say that you have to test all residents and staff weekly until 14 days after you don't have any positives. So I wouldn't call it baseline anymore, but you are going to have to do follow-up testing of all staff and all residents.
All right, so I'm not seeing any other questions, but as you can see up on the slide right now, we do have those emails. We have the Safe and Calm. You can reach out to Deanna, Dalton, or Laura Funch, and they should be able to answer any questions that you have. If not, they will make sure to get the answer for you. Just a quick reminder, we have a busy week next week. So we have a Housing Matters program that you can go ahead, and that will be on Tuesday, June 16th from 9 to 12:30 p.m. Eastern Standard Time. As I mentioned earlier, we do have the reimbursement and strategies on Thursday, and that will be from 12 p.m. to 2 p.m. Eastern Standard Time, as well as we will be having these COVID-19 webinars on Wednesday at 10 a.m. Eastern Standard Time, and then another one on Friday at 11 a.m. Eastern Standard Time. So a busy week for us. Make sure you can join us for those. Sign up if you'd like. Just would like to thank both Deanna and Dalton for the information today. We would also like to thank, I believe we had around 70 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything that you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I think that takes care of everything for me. Deanna or Dalton, would you like to say anything else?
No, just that we hope that everyone has a great weekend, and we will talk to you all next week.
Thank you. Have a great day, everyone.
Thank you all.
Take care.